I'm Anna Martens, a second-year pediatric resident, and I'm going to tell you about our study titled Providers' Preferences when Evaluating Suspected Multisystem Inflammatory Syndrome in Children, also known as MISC. It was a cross-sectional vignette-based survey. MISC is a rare but severe complication of COVID-19 and can result in life-threatening cardiac disease and death. Guidelines are currently evolving to aid in diagnosis. However, the testing we currently have lacks specificity. In our study, we aim to understand practitioners' preferences when initiating a workup for a pediatric patient presenting with possible MISC through a vignette-based survey. Survey participants were mostly physicians from the U.S. at academic medical centers. When asked if they would initiate a workup for greater than 24 hours of fever and nonspecific symptoms, 80% of providers would not, despite this being part of the recommendation from the CDC. The majority of patients would trigger a workup for fevers greater than 72 hours or clinical deterioration. Skin rash, abdominal pain, and shortness of breath were the most commonly cited symptoms that raised provider concern for MISC. While these symptoms are not specifically cited in the CDC case definition for MISC, these symptoms are seen quite commonly in confirmed cases. Providers were then asked specifics about the workup they would perform if they were concerned about MISC. As you can see in the top left graph, 91% of providers would obtain COVID antigen or PCR testing. Blood work would be obtained by 86% of providers, which, as you can imagine, can be very challenging in the pediatric patient population. When providers do order blood work, there are a large number of tests obtained, which is in line with the current recommendations. You can see these recommendations off to the right in this chart, which is written by the American College of Rheumatology and is a widely accepted guideline for MISC workup. However, these lab tests are not specific to MISC. The most commonly obtained tests were CBC, CRP, ESR, and chemistry. Additionally, 73% of providers would obtain COVID-19 antibodies. However, with 6 million kids testing positive for COVID thus far, we can expect that eventually most kids will develop antibodies at some point, whether it is post-vaccination or post-infectious, so this laboratory marker will become even less specific. Consults are also frequently obtained, and as our busy ID and cardiology colleagues know, they are the most commonly consulted, followed by rheumatology. The most common findings that providers felt would confirm the diagnosis of MISC were elevated cardiac enzymes and severe illness requiring admission to a pediatric intensive care unit. Additionally, abnormal echocardiogram was also high on the list. While cardiac involvement is one of the most feared complications of MISC, it is not necessary to diagnose MISC. Therefore, heavy reliance on cardiac findings to confirm the diagnosis could mean that providers are missing or underreporting cases of MISC. And finally, these charts demonstrate the amount of time providers feel it takes to confirm or rule out a diagnosis based on the provider's experience. The majority of participants felt that it took 24 to 48 hours for both confirming and ruling out MISC. In conclusion, MISC is challenging to diagnose and the criteria need to be refined. Our study shows that there is significant heterogeneity amongst providers in regards to starting the workup, the order and content of the workup, and the criteria used for diagnosis of MISC. A diagnostic test specific for MISC is needed to streamline the workup, prevent unnecessary admissions, and reduce the costs. And additionally, it should be feasible for all patient care environments.